I'm Dr. Fakir Raveri, and this is nosocomial pneumonia in adults. The first learning objective is given a patient with hospital-acquired or ventilator-associated pneumonia, design appropriate empiric therapy. At this point, you should know that community-acquired pneumonia is relatively less severe type of pneumonia caused by less resistant pathogens such as strep pneumo, H. flu, Moraxella catarrhalis, and atypical organisms. When we look at the ventilator-associated pneumonia, it's relatively a more severe disease with mortality as high as 30%, and is typically caused by more resistant pathogens. So the organisms that you want to target empirically are Staphylococcus aureus, which could include methicillin susceptible Staphylococcus aureus or methicillin resistant Staphylococcus aureus, as well as gram-negatives such as Pseudomonas aeruginosa, Klebsiella pneumoniae, and Acinetobacter species. And these organisms are usually more likely to be drug resistant. Because VAP is caused by drug resistant organism, it is extremely important to be aware of drug resistant variations. These variations in resistant patterns can occur at country level, so different countries have different patterns. Within regions, so different cities or different parts of a large city may have different patterns, as well as hospitals. Different hospitals can have different patterns of resistance. Even within a single institution or single hospital, different ICUs can have different resistant patterns. And of course, another thing that's important to know is the source of specimen. For example, if we have organisms from the urine versus organisms from the pulmonary specimen, they can have different resistant patterns. And that's why it's recommended that all hospitals regularly generate and disseminate local antibiogram, ideally one that's specific to their ICU populations if possible. And it's recommended that hospitals do this at least once a year. Now, one key recommendation from the guideline is that while we want to empirically cover for Staphylococcus aureus, if based on the local resistant patterns, it's unlikely to be, Staphylococcus aureus that's MRSA, it's probably okay to just cover for MSSA instead of MRSA. Now, in real world, I haven't really seen any physicians that would not cover MRSA in patients with VAP, but the guideline is making a point that if based on resistant patterns are likely to be MRSA, it's probably okay to only target MSSA. And there are some agents that cover Pseudomonas as well as MSSA. So Piperacillin-tazobactam and Cefepime, for example, cover Pseudomonas as well as MSSA. And while they do not cover MRSA, if based on local resistant patterns, we think that it's unlikely to have VAP due to MRSA, it will be okay to use them. Now, who exactly needs to receive empiric coverage for MRSA? Generally speaking, both MRSA and Pseudomonas are organisms that originate from the healthcare settings. So patients who have received prior IV antibiotic in the past 3 months or 90 days need to receive one agent that has coverage for MRSA, so typically Vancomycin. Also, patients with VAP who are being treated in the ICUs where the prevalence of MRSA is more than 10 to 20%, or if the prevalence of MRSA is not known, these patients need to receive one agent that is active for MRSA. Now, the same is true for Pseudomonas when it comes to IV antibiotic treatment in the past 90 days. Now, with Pseudomonas, it's recommended to use 2 agents that are active against Pseudomonas empirically. Especially in ICUs where when the susceptibility rate of Pseudomonas to the agents that we're using are less than 90%. In other words, the resistance rate is more than 10%. Or if the rate of susceptibility on the antibiogram is not available, or if the patient has a structural lung disease such as cystic fibrosis. So these patients need to receive 2 agents that are active against Pseudomonas empirically until we get susceptibility results back. Now, if we are in a ICU where the susceptibility rate for a specific agent is more than 90%, in other words, the rate of resistance is less than 10%, then a single agent is sufficient. Now, keep in mind that most anti-Pseudomonal antibiotics, with the exception of de-escalation, do not cover MRSA. So when we use two agents that are active against Pseudomonas, we typically end up adding a third agent for coverage of MRSA. So typically vancomycin. And the reason the guideline recommends two agents active against Pseudomonas for empiric therapy is that in case one of the agents doesn't cover the Pseudomonas, the other one should cover it. And this is not for every patient. These are patients that are at risk of having multi-drug resistant Pseudomonas. And of course, once a pathogen has been identified and susceptibilities are known, there is no reason to continue combination therapy. Now, your MRSA coverage antibiotics are typically vancomycin and linezolid. It's important to not use daptomycin, so you should avoid daptomycin because it's inactivated by surfactant. Now, alternatively, ceftaroline is also available should the patient be unable to take vancomycin or linezolid. But the evidence is with vancomycin and linezolid. Now, for the two agents that we use for Pseudomonas, one should be a beta-lactam, and then a second one should be a non-beta-lactam. So the beta-lactams that we choose are Piperacillin-tazobactam, Cefepime, Ceftazidime, Meropenem, Meropenem, or Aztreonam. And non-beta-lactam would be ciprofloxacin, levofloxacin, amikacin, gentamicin, tobramycin. Now, we also have polymyxins like colistin and polymyxin B that are usually reserved as last line. So let's say if someone has received IV antibiotic in the last 90 days, so let's say somebody received ceftriaxone 2 weeks ago and now they have ventilator-associated pneumonia, we can choose an MRSA active agent like vancomycin plus one agent from beta-lactam that's active against Pseudomonas. So we can use Piperacillin-tazobactam, for example, and plus a second agent, so ciprofloxacin. So the patient will end up receiving three agents. So ciprofloxacin plus Piperacillin-tazobactam plus vancomycin. It is extremely important not to use aminoglycosides as monotherapy. So if you were to use gentamicin, for example, it has to be in combination with one of these beta-lactams. Because there has been, in the studies that we have with aminoglycoside monotherapy, the rate of mortality was higher. Now that we know how to treat ventilator-associated pneumonia, let's take a look at treatment of HAP. So for the most part, we follow the same principles. Majority of evidence is with WAP. So we have fewer studies with hospital acquired pneumonia. So majority of these recommendations are derived from WAP. So I let you, so you can see that, IV antibiotic in the past 90 days is still driving most of these recommendations. And you can see that we use the same antibiotics. So if someone has HAP and is not at risk for mortality and no risk factors for MRSA, they can receive a single one of these agents. So these agents will cover Pseudomonas as well as MSSA. Whereas if someone is at risk for MRSA, but not at risk for mortality, they can receive one of these agents for Pseudomonas, plus either vancomycin or linezolid to cover for MRSA. And of course, if someone is at high risk for mortality, then that patient should receive two agents for Pseudomonas plus one agent for vancomycin. So one of the beta-lactams plus one of the non-beta-lactams active against Pseudomonas plus an agent for MRSA. We designed appropriate empiric therapy for HAP and VAP. Now, given macrobiological results, let's de-escalate from empiric therapy to pathogen-directed therapy. In general, there are a lot of different types of bacteria, and they could be part of the normal flora, so they are actually essential for the normal human health, or they could be colonized, which means that bacteria that are not part of the flora could actually be in part of the GI tract, for example, and not necessarily cause an infection and just colonize it. Now, whether colonized or as part of normal flora, bacteria occasionally can have resistant genes. So let's say the red bacteria here are resistant to antibiotics and the blue ones are susceptible. And keep in mind that this is just part of the flora, not necessarily an infection. Now what happens every time that we use antibiotics is that the antibiotic, while we use it to treat an infection, what it does to the actual flora is that it actually wipes out all the ones that are susceptible to that antibiotic, and the ones that are resistant to that antibiotic will stay behind because the antibiotic could not kill it. Now again, those bacteria were not really causing an infection, they were just part of the flora. But when we use the antibiotic, we actually selected for them, and now they have the opportunity to become the dominant bacteria in the flora. Or if they were just a colonization, now they become the dominant organisms in the body. And keep in mind that they all have the genes for resistance to antibiotics. Now, occasionally, if someone gets actually infected, what happens is that these bacteria that have the genes, the resistant gene, they can actually transfer it. So they can donate that gene to a pathogen, which will cause drug-resistant infection. This whole process is referred to as selection pressure. Which brings us to the concept of broad versus narrow spectrum of activity. So generally speaking, broader antibiotics are more likely to cause selective pressure because they can wipe out, more clinically significant organisms and leaving behind the resistant organisms. Now, when it comes to broad versus narrow, the generally accepted definition is based on gram-negative coverage. It's not so much about a head count, so it's not about how many organisms an antibiotic covers. It's more about which organisms does it cover. So it's about clinically significant organisms. So in order to understand if a drug is broad or narrow, you should ask yourself the following question. Does it cover carbapenem-resistant Enterobacteriaceae? Now, CRE, such as E. coli and Klebsiella, that are resistant to carbapenems, we don't have a lot of antibiotic options for them. So this is one of the most resistant pathogens available. So if we have antibiotics that's active against CRE, we should reserve it for CRE. So this is considered the broadest class of antibiotics. The next question you should ask yourself is, does the antibiotic cover multi-drug resistant Pseudomonas? If so, it is very broad and it should be reserved for multi-drug resistant Pseudomonas. Another question to ask is, does it cover Pseudomonas period? Because Pseudomonas can select for resistance very quickly, if you are not treating Pseudomonas, you should not be using a drug that's active against Pseudomonas if possible. And the next question is, if a drug covers ESBL Enterobacteriaceae, it should be reserved for ESBL organisms if possible. And lastly, if a drug is more likely to disturb the gut flora and lead to Clostridioides difficile infection, we should use an alternative if possible. Here's a pyramid to help us compare broad and narrow spectrum of activity of antibiotics. So the higher you are on the pyramid, the narrower the spectrum of activity, and the lower you are on the pyramid, the broader the spectrum of activity. Now I have created a tiering system, so tier 1, 2, 3, 4, 5, 6 doesn't really exist. I just created this to help us understand and compare different antibiotics when it comes to broad versus narrow. So in tier 1, I would place Cefazolin, which is a first generation cephalosporin, and Trimsulfa and Amoxicillin. And that's because when it comes to gram-negative spectrum of activity, these agents have limited activity, limited to protease, E. coli, and Klebsiella species. Now, these organisms can still develop resistance to this, but in general, the activity of these agents are limited to wild type P, E, and K. Now, in tier 2, I would place drugs like Ceftriaxone, which is a third generation cephalosporin, and Empiric, which has expanded activity when compared to amoxicillin. And in addition to protease, E. coli, and Klebsiella, these agents are also more likely to cover Haemophilus and Neisseria species. Now in tier 3, I will place Erdopenem and gentamicin. Erdopenem is the only carbapenem that does not have activity against Pseudomonas, so therefore it is in tier 3 because these agents do not have activity against Pseudomonas. Now, as of 2023, gentamicin is no longer considered active against Pseudomonas, and that is based to update the review of its PK/PD characteristics. So with the safe doses that we use in patients and with the current MIC in Pseudomonas species, gentamicin is not likely to cover Pseudomonas. So for that reason, it has been placed in tier 3, and these agents do not have activity against Pseudomonas, but they are active against ESBL, so that gives them the advantage over tier 2. So if you have Enterobacterales that are producing ESBL, they will essentially be resistant to the drugs beta-lactams in tier 1 and 2. So ertapenem will be drug of choice for ESBL producing Enterobacterales for severe infections such as bacteremia. And gentamicin, of course, is not affected by ESBL since it's an aminoglycoside. And both of these agents also have extended activity against more gram-negative organisms. So Citrobacter, Providentia, Enterobacter, and Serratia. And they do not have activity against Acinetobacter. Now, when it comes to tier 4, this is when we really start to define broad spectrum because of activity against Pseudomonas. So essentially, this is where most experts would agree, where we draw the line between broad and narrow, because Pseudomonas species can develop resistance relatively easier compared to other organisms. So if you are not suspecting Pseudomonas when you're treating an infection empirically, we shouldn't use an agent that's active against Pseudomonas when we have multiple options. So this is literally the beginning of broad spectrum, and these are drugs that are pretty much active against wild type Pseudomonas aeruginosa. So ciprofloxacin, levofloxacin, tobramycin, Cefepime, Ceftazidime, and Piperacillin-tazobactam are the most common ones. And I say wild type because, again, Pseudomonas can develop resistance to these agents, but wild type essentially, where these agents will have intrinsic activity against Pseudomonas. And that's why we have a tier 5. These are agents such as the rest of carbapenems. So remember, ertapenem doesn't have activity against Pseudomonas, but the rest of carbapenems do. And also ceftolozane-tazobactam. Ceftolozane-tazobactam was specifically designed to be having potent activity against multi-drug resistant Pseudomonas. So when Pseudomonas is resistant to drugs in tier 4, that's when these drugs come in. So, we don't really want to use these for all Pseudomonas. We really want to reserve them for when Pseudomonas turns into multi-drug resistant Pseudomonas. So for that reason, these are typically reserved or restricted in hospitals, and they will require approval for use just to make sure that the ID or antimicrobial stewardship team can get a second look and make sure that their use is appropriate, because the more we use these agents, the more likely that we will lose them to resistance. So we really want to use them judiciously. And then tier 6, they are still active against multi-resistant Pseudomonas, but in addition, they also have activity against carbapenem-resistant Enterobacterales. So some Enterobacterales, of course, can develop ESBL, but the smaller portion of them can also develop resistance to carbapenems. So if, we have E. coli resistant to Meropenem, for example, that's when we want to go to tier 6. So these are really reserved for when we have these difficult to treat organisms. So cefiderocol, ceftazidime, avibactam, and some of these carbapenems combined with beta-lactamase inhibitors. So meropenem, vaborbactam, imipenem, relibactam, and also some other classes. So polymyxins, so polymyxin B and colistin, as well as plazomycin, which is an aminoglycoside, the most recent aminoglycoside, has good activity against these agents. They also have a tier 6B because there are agents that are active against CRE and ESBL, but they actually do not have activity against Pseudomonas. So there are actually a hole in tier 6B, but still these are pretty broad, even though they don't have activity against Pseudomonas, because they are active against CRE. So we really want to reserve these for when we don't have other agents available, because when we get infections due to CRE, we really have limited options. And by the time we get to CRE, it's really easy for these organisms to be resistant to multiple classes of antibiotics. So tigecycline, eravacycline, and amikacin, these are they may have activity against CRE, but they don't have activity against Pseudomonas. So amikacin, just like gentamicin, as of 2023, is no longer considered active against amikacin for systemic infections based on its updated review of PK/PD characteristics. The only time that it will be okay to use amikacin for Pseudomonas is if it's in urinary tract infections, and that is because a high concentration of amikacin can be achieved in the urine, and that can meet the PK/PD parameters. But outside of the urine, pretty much based on current circulating organisms, MIC, amikacin is no longer considered active against Pseudomonas for invasive infections. One thing I want to mention about Acinetobacter. Acinetobacter is also an organism that can easily develop resistance to multiple classes of antibiotics. So I mentioned that tier 3 doesn't have activity against Acinetobacter. Now in tier 4, it is depending on the agent, it may or may not have activity against Acinetobacter. And even at tier 5 and 6, even though I have A here in case for Acinetobacter, you really need to check for susceptibility, because Acinetobacter may or may not be resistant to these agents, because again, it's really easy for Acinetobacter to develop resistance to multiple classes of antibiotics. So when it comes to gram-positive, we discussed the risk factors for MRSA. So empirically, you will have an agent like Vancomycin or Linezolid for MRSA, and once the culture and susceptibility results come back, and if it is MRSA, then we continue Vancomycin, and then you can discontinue the antibiotics for Pseudomonal coverage. Alternatively, if the results come back and it is not MRSA and it is MSSA, then you should discontinue Vancomycin and start the patient on oxacillin or naphthalene or cefazolin, because these are tier 1, these are tier 1 or antibiotics, and you should discontinue any other agent for Pseudomonas. Now, if the patient actually happens to have Pseudomonas, then you should use the results of antimicrobial susceptibility to see which one is susceptible and use it. Now, generally speaking, only one agent is sufficient when it comes to pathogen-directed therapy. Occasionally, you can use 2 agents if the risk of death is high in the patient. For example, septic shock would be an example. So if a patient is still in the ICU on pressors, in order to maintain normal blood pressure, that patient could benefit from 2 agents, even for definitive therapy. Again, it's important to avoid aminoglycoside monotherapy. Even if Pseudomonas is susceptible to aminoglycoside, you should not use aminoglycoside monotherapy. You can only use aminoglycoside as a part of a combination. So, for example, you can use aminoglycoside plus Cefepime. Now, when it comes to multi-drug resistant pathogens, you can also add inhaled therapy. So one of the problems is penetration to the lungs. So if it's difficult for many of these antibodies to actually get to the site of infection, so inhaled therapy will actually deliver the antibiotics to the site of infection, which is the lung. But inhaled therapy should never be monotherapy. It's always an add-on. So you add it to your IV therapy. So if someone is getting Cefepime and IV tobramycin, and you can add inhaled tobramycin on top of it. So inhaled tobramycin is not to replace IV tobramycin. And lastly, if you do have an ESBL agent in the lungs, the guideline doesn't make a specific recommendation, so you can use anything that's susceptible. Now, historically, we have said that carbapenems are drug of choice for ESBLs, and it has been subject to some controversy in recent time. Recently, there was a study, the Merino study, that showed that when it comes to bacteremia, carbapenems are better than Piperacillin-tazobactam because it reduces mortality. So my recommendation is to, also use carbapenems for pneumonia. But basically, we have limited data when it comes to pneumonia with ESBLs. We designed appropriate empiric therapy for HAP and VAP, and we de-escalated from empiric therapy to pathogen-directed therapy. Now let's evaluate a patient's clinical stability to determine if antibiotic therapy can be switched from IV to PO. Now, IDSA guidelines for community-acquired pneumonia gives us some guidance for switching patients from IV to PO. Now, keep in mind that community-acquired pneumonia can be treated as outpatient in, moderate or less severe patients, whereas in hospital patients, the patient will receive IV antibiotics. So, based on IDSA, patients who are hemodynamically stable and clinically improving can be, can be switched from IV to PO as long as they are able to tolerate oral therapy. Another thing to consider is to make sure that the GI tract is also functional. And we can apply some of these principles to patients with nosocomial pneumonia. Now, the reason we want to switch patients from IV to PO as soon as possible, when they can tolerate it, is, first of all, to make sure that we don't introduce any, line infections, as well as getting patients ready to be discharged. However, keep in mind that the guidelines do say that inpatient observation while receiving oral therapy is not necessary. So if the patient is ready to be discharged from the hospital and they're on IV antibiotics, and it's okay to discharge them and send them home with oral antibiotic. It's not necessarily to keep them one extra day to make sure that they tolerate the oral antibiotics. Now, there was a systematic review published in JAMA in 2016 that looked at the evidence for, criteria helping transition patients from IV to PO. So basically, absence of mental confusion, ability to take oral medications, absence of fever, hemodynamic stability, which is defined as heart rate less than 100, and of course, systolic blood pressure greater than 90. This is without using pressors. So, without using norepinephrine, the blood pressure should be greater than 90. Another criteria is respiratory rate lower than 25 and oxygen saturation higher than 90%. And of course, we have to make sure that the patient is clinically improving before we change from IV to PO. And sometimes the patient may not be improving, and there could be different reasons for it. One reason, of course, could be that we have identified the correct organism, or empirically we are targeting the right organism, but we use the inappropriate antibiotic, or we were using the wrong dose. So it's important to, target the right organisms, use the right antibiotics, and also use the right dose. So, we have to make sure that the dosing is appropriate based on body weight, based on renal function, based on hepatic function, and based on drug disease, and drug-food interaction. So as pharmacists, we have to take all of those considerations to make sure that the patient is receiving the right dose. And along with the dose also goes the right frequency. The frequency is also important. Sometimes, the organisms can develop resistance while on treatment. So it's, another thing to consider if the patient is on the right drug and on the right dose. You may want to question, whether the organism developed resistance while the patient was on the antibiotics. So sometimes we may send another culture just to make sure that the organism is still susceptible to the antibiotics we're using. I talked about the wrong dose. Sometimes the patient may miss a dose. So let's say the nurse comes to administer the antibiotic and the patient is not available. So whether the patient was sent for imaging or the patient, was not available for any reason, that's important to consider, to talk to our nurse colleagues to make sure that the antibiotics were actually administered. Another thing is to make sure that the antibiotics are actually getting to the site of infection. So sometimes, if the if the organism is in a specific area where antibiotics cannot get, source control becomes really important. So empyema, for example, is an example, when we actually need to make sure we have source control because antibiotics may not be able to get there. So it's important to actually drain the site of infection. In the case of pneumonia, sometimes the patient may still have like shortness of breath and not seem like they're getting better, and could be due to other reasons that has nothing to do with pneumonia. And of course we have to target the right organism and use the right empiric therapy to target those organisms. And also we should think of non-infectious causes. If the patient has fever due to either a clot or cancer, non-infectious causes of fever. Sometimes you may have drug-induced fever. So beta-lactams, for example, occasionally cause drug fever. And lastly, presence of an unrecognized concurrent infection. So if you're trying to target pneumonia and suddenly the patient has, bacteremia that led to endocarditis, that could be something that's, could be the reason why the patient is not doing well. And that's important to consider. Given a patient with HAP and VAP, we design appropriate empiric therapy, and given microbiological results, we de-escalated from empiric therapy to pathogen-directed therapy. We also evaluated a patient's clinical stability to determine if antibiotic could be switched from IV to PO. Now, let's recommend an appropriate duration of therapy for HAP or VAP. Now, prior to the 2016 IDSA guideline for HAP and VAP, it was usually the question of whether we should treat for 1 or 2 weeks when it comes to, VAP and HAP patients. And it was primarily due to the NUME study, which was published in JAMA in 2003, which looked at 8 days of treatment versus 15 days of treatment. And what they found was that there was actually no difference in mortality between the two groups, whether the patient received 8 days of treatment or 15 days of treatment. However, when they did subgroup analysis, in the group of patients who had VAP due to non-lactose fermenting organisms such as Pseudomonas and Acinetobacter, there was increased recurrent infection in the group of patients who received 8 days of treatment. And because of that, we started to treat patients who had VAP due to Pseudomonas or Acinetobacter for 14 days. Now, things started to heat up when a Cochrane review in 2015 compared short-term therapy to long-term therapy in patients with HAP and VAP, and found that in a group of patients who actually got short course of antibiotics for, let's say, 7 or 8 days, there was actually increased 28-day antibiotic-free days and reduced recurrent VAP due to multi-drug resistant pathogen. In other words, patients who had longer duration of therapy, they actually had more multi-drug resistant pathogens. In addition, there was no difference in mortality, recurrent pneumonia, treatment failure, or hospital length of stay when you compare the two groups. And they did still find that in group of patients who had Pseudomonas Acinetobacter, short course of antibiotics were associated with recurrent infection, but no other differences. So while these patients had the recurrent infection, those recurrent infections were less likely to be due to multi-drug resistant pathogens. So they were easy to treat. Whereas patients who had longer duration of treatment, while they were less likely to have recurrent infections, those recurrent infections were more likely to be multi-drug resistant. There was also a study published in Chest that showed that short course regimen compared to long course therapy was not associated with any difference in mortality, recurrent pneumonia, ventilator-free days, or duration of mechanical ventilation, or length of ICU. So what happened in 2016 when the IDSA guideline came out is that the panel actually did their own systematic review and meta-analysis, and they found that the specific subpopulation with VAP due to non-glucose fermenting gram-negative organism was analyzed, and no difference was observed for pneumonia recurrence. So here's what the IDSA guideline recommends for length of therapy of VAP. They actually recommend a 7 days course of antimicrobial therapy rather than a longer duration. However, this recommendation is not to replace clinical judgment. So there may be situations in which a shorter or longer duration of antibiotic may be indicated, depending on whether the patient is clinically improving or deteriorating based on radiologic and laboratory parameters. But for most patients, 7 days of antibiotics is likely sufficient. And we can extrapolate from the VAP evidence and make basically the same recommendation for patients with HAP. So also for HAP, the guideline recommends 7-day course of antimicrobial therapy, but this is not to replace clinical judgment.